In this video, we are going to see what is hematopoietic stem cell transplant, or which is also called bone marrow transplant. Now, what is bone marrow transplant? Administering healthy hematopoietic stem cells to patients with dysfunctional or depleted bone marrow. It can also generate functional cell and replace dysfunctional cell in conditions like immune deficiency syndromes, hemoglobinopathies, and some other conditions. Now, before we go to the bone marrow, actually, we need to remember a few terms. One is major histocompatibility complex. This is class 1 and class 2. These are actually a group of genes present on the short arm of the chromosome number 6, which generate HLA, that is human leukocyte antigens. Now, what are human leukocyte antigens? These are proteins which are present on the surface of the cells, and they play essential role in alloimmunity. Now, these are again class 1 molecules and class 2 molecules. The class 1 molecules are HLA-A, B, and C. They are recognized by the CD8 positive T lymphocytes. While then you've got class 2 molecules which are called HLA-D, P, DQ, and DR. They are found on antigen presenting cells, and they are recognized by CD4 positive cells. Then we got syngeneic bone marrow transplantation, that is transplantation between two identical twins. Then we got autologous bone marrow transplantation, is the bone marrow products are collected, stored, and they are retransfused back into the same patient. So this is called autologous transplantation, and this is usually done after the bone marrow is purified. And then you got allogenic transplantation. Allogenic transplantation is HLA matched family members, unrelated donor which is HLA matched, or a mismatched family donor which is called haploidentical. And then we got engraftment. Engraftment is actually a process by which infused transplanted hematopoietic stem cells, they produce mature progeny in the circulation. And then we got reparative regimen, which is high dose chemotherapy or total body irradiation, or both of the recipient, so that we destroy the immune system. Now, what are the indications? They are malignant diseases and non-malignant diseases. Malignant diseases, most of them are hematological diseases. For example, multiple myeloma, Hodgkin's and non-Hodgkin's lymphoma, acute myeloblastic and acute lymphoblastic leukemia, proliferative neoplasm like CML, polycythemia vera, essential thrombocythemia, primary myelofibrosis, and then chronic lymphocytic leukemia. Then it's myelodysplastic syndrome. It can be used in other tumors like solid tumors, medulloblastoma, metastatic breast tumors, and testicular germ cell tumor. And then there can also be indication in non-malignant conditions. For example, aplastic anemia, which is an autoimmune destruction, severe combined immunodeficiency, thalassemia, sickle cell disease, and conditions like chronic granulomatous disease, leukocyte adhesion deficiency, Chidiac-Higashi syndrome, Costman syndrome, Fanconi's anemia, Blackman-Diamond anemia, and enzymatic disorders. It is also being used now and tried in autoimmune conditions like systemic sclerosis and systemic lupus erythematosus. Now, virtually there is no contraindication to bone marrow. It's actually the indications and the fitness of the patient. The patient is fit to receive, then bone marrow can be transplanted. Now, what are the complications? There may be acute complications which generally occur within 90 days. They sometimes may occur after 90 days, but generally in the 90 days. These include myelosuppression with neutropenia, anemia, or thrombocytopenia. There may be sinusoidal obstruction syndrome. There may be mucositis. There may be acute graft versus host disease. There may be bacterial infection with gram-positive and gram-negative organisms. There's herpes viridae infections, fungal infections with Candida and Aspergillus. Then you've got chronic complications which come after 90 days. There can be chronic graft versus host disease, infection with encapsulated bacteria, and reactivation of the varicella zoster virus. So these can be the potential complication. Now we see briefly one by one these complications. Now, important thing is infection prevention in these patients. Infections are at a great risk of developing infection. Levofloxacin a day first post-transplant, until the ANC is greater than 1000 per microliter, or until the discontinuation of prednisolone in cases of graft versus host disease. So the levofloxacin continue. Then prophylaxis against pneumocystis jirovecii, trimethoprim sulfamethoxazole is used. It is used twice weekly until off immunosuppression. And then fungal infection, you can use fluconazole, voriconazole for 1 month. In serious cases or more severe cases, voriconazole may be preferred over fluconazole. Acyclovir for 1 month to prevent herpes simplex virus, and 1 year for varicella zoster virus. Encyclovir for PCR proven CMV infection can be used, and then metronidazole or levofloxacin for cord colitis. And then you've got sinusoidal obstruction syndrome, which was called veno-occlusive disease. There is tender hepatomegaly, there may be jaundice, bilirubin may be 2 mg or more than that, ascites, and weight gain due to fluid retention. There is endothelial damage in the hepatic sinusoid leading to obstruction and necrosis of the centrilobular liver from oral busulfan and cyclophosphamide. So these are the drugs. That's why sometimes intravenous busulfan may be useful and doesn't produce this problem. Ursodeoxycholic acid given pre and post transplant may be helpful. And now defibrotide has shown efficacy in patients who have developed the sinusoidal obstructive syndrome. Then graft rejection or failure, loss of bone marrow function or no gain of function after an infusion is the graft rejection or failure. The incidence of failure is highest when there is HLA disparity. It's less in patients who got HLA matching. Functional residual host response to the donor cells. So if proper priming is not done, the functional residual host immunity destroys the donor cell. If there is a low number of infused cells, or there is in vitro damage during collection and cryopreservation of the donor, inadequate preparative regimens and infections, they can cause this. Failure, chimerism, that is presence of cell population from one person in the blood of another person is chimerism, is an important step in ensuring engraftment and success of the transplantation. Expression of CD33 indicates the presence of granulocyte, and expression of CD3 indicates the presence of T cells, and confirming that most of the cells present are from the donor, so that screening may be helpful. And graft versus host disease, a reaction between donor T lymphocytes in an allogenic transplant and the recipient's HLA polymorphic epitopes. Graft versus host disease may be acute or chronic. In acute, graft versus host disease usually develops within 3 months. There is calcineurin inhibitors, methotrexate, and antithymocyte globulins are used for prophylaxis. High-dose prednisone or methylprednisolone is used to treat high Gluckberg's grade disease. Then chronic graft versus host disease occurs after 3 months. It involves multiple organs. It is similar to collagen vascular disorders. Treatment is with high-dose steroids for 2 years or more as per NIH grades. Idiopathic pneumonia syndrome usually occurs in the first 90 days post-transplant. Due to the direct cytotoxicity of the preparative regimens, treatment is with steroids. Etanercept has been studied, but combining TNF inhibitors to steroid has not shown any added benefits. Now the toxicity, pancytopenia secondary to chemotherapy, radiotherapy, and post-transplant immunosuppression results in destruction of neutrophils, macrophages, monocytes, lymphocytes. It can lead to life-threatening infections. There should be vaccination against multiple organisms like pneumococcus, tetanus, diphtheria, pertussis, H. influenzae, meningococcus, polio, HBV, influenza, measles, mumps, varicella zoster, and rubella. European Group for Blood and Marrow Transplantation risk score can be used for risk assessment of these patients. So these are different problems we see in a patient who's got bone marrow transplantation.